This is a continuation of the first trimester health maintenance that we do in that first prenatal visit and during the first trimester. So we're going to talk about risk assessment, and it's all based on any lifestyle habits, chronic illnesses, etc., that this woman is bringing to the pregnancy. We need to discuss genetic risks to determine whether or not this patient has risk of having abnormal chromosomes or abnormal fetal development. And some of the indications that would lean towards this referral is if they have advanced maternal age. So any woman greater than or equal to 35 years of age is put in that high risk category. Have they previously delivered a baby that had some type of an anomaly that's unexplained? Is there a family history of genetic defects, and how strong is that history? Are either the patient or the father of the child at increased risk of having an abnormality due to being an Ashkenazi Jew, because they're at risk for Tay-Sachs, Tay-Sachs disease? These offspring have a very limited lifespan, and it's not very, very nice. Are they first cousins? These things are important because it increases the risk of a genetic anomaly. And then we also discuss the tests that we have available to screen for Down syndrome as well as neurotube defects. So there will be a separate video link to a YouTube that discusses the Harmony test that you need to watch. And in your preclinical paperwork that you have to do, you are going to be looking up the different tests that we have for neurotube defects. And I do have a small description at the end of this lecture. So prenatal labs, we do quite a few. It's almost overwhelming for the patient because we collect a lot of tubes and samples. It can be overwhelming for the nurse because the nurse is responsible for making sure that all the paperwork is done correctly and all of the tubes are labeled and that everything is sent off to the lab. So during the pelvic exam, we're going to do a pap smear, possibly an HPV test, and a cervix culture. And there's a couple caveats of when do we do a cervix culture. One, if they're symptomatic, and two, if they're at risk. So any female less than 25 has a high risk of acquiring chlamydia. So we fairly routinely will screen them. If a patient is planning on having a CVS, which means chorionic villus sampling, which refer back to your preclinicals that you had to complete as to what that test is, they need to have a gonorrhea and chlamydia culture done within 2 weeks of having that procedure done, because we are doing a transcervical approach to getting tissue to send to the genetics lab. We don't want to introduce gonorrhea or chlamydia into the womb. We obtain a urine sample. We can get one simply to do an HCG to validate the pregnancy. We get a urinalysis, and in particular what we're looking for is the protein and the glucose. And if a woman on her first prenatal visit in the first trimester has positive protein and or positive glucose, we flag her as a high-risk pregnancy. And we're going to look for kidney disease. Do they have hypertension? Are they a known or an unknown diabetic? In which case we are going to go ahead and do the glucose test. Every pregnant woman gets a urine culture and sensitivity, and if it's positive, we will treat, and then we do a test of cure 2 weeks later. If that test of cure is positive, then we tend to treat this woman with macrodantin every night throughout the pregnancy, because urinary tract infections increase the risk of developing preterm labor, which is a separate lecture. Now, the blood tests that we collect on pregnant women include a CBC, primarily getting baseline on the white cells, hemoglobin hematocrit, and the platelets, but we're also making sure this woman isn't anemic early on. We expect it in the mid-trimester, but not in the beginning. If they are anemic, we treat with iron. We get a blood type and RH. RH is an antibody. And then a separate test that you really need to understand this is the antibody screen. Now, yes, we're primarily looking to see, is she Rh negative and has she been sensitized because she's had a previous child that was Rh positive. But there are several other antibodies that can also have an adverse outcome on the fetus, and that will be in a separate lecture regarding the Rh negative patient. We collect a hepatitis B surface antigen on every patient, and some practices based on the population risks will get a hepatitis C as well. Everyone gets a rubella titer. If it is negative, we counsel the patient regarding the need to get the vaccine after they deliver, and in the interim, stay away from anyone who has a rash-like illness. Our syphilis test is either the RPR or the VDRL. And then based on the risk assessment, we offer the HIV test. Now, if they opt to get the HIV test, you do need to obtain the consent, and this consent is not only for having the test drawn, but it also will denote whether or not we can forward those test results if the records are ever to be transferred to another facility. And that would include going to the hospital. We send all prenatal records to the hospital as they begin their third trimester so that in labor and delivery, we know what to anticipate. Patient education is oftentimes overwhelming for this patient. You may be feeling overwhelmed already based on what we do at that first visit. So imagine what it's like to be the patient and we are constantly feeding them information. So we mention things and then every time they come back, we reiterate our counseling. So the first is to discuss the discomforts of pregnancy that they may be having. So nausea and vomiting. We talk about eating bland foods, not eating before they go to bed, having crackers at the bedside. For fatigue, yes, they're very fatigued and they need to have more rest. Urinary frequency and breast tenderness are actually good things. And so I like to turn it around to say, you know what, that means that you are truly pregnant because this is what we expect and it's normal. And oftentimes that's enough to make them feel comfortable. Related to the preventive health so that we have the best outcome for the mother and the baby is warning signs. Bleeding. Bleeding is common, but we don't consider it normal. If they have bleeding, they need to contact us. If it's bleeding heavy like a period with cramps, no matter what time of the night or day or weekend, they need to call the provider. If it's just scant blood on the toilet paper, especially if it's after intercourse, they can wait till the office hours are open between 9 and 5. We counsel women who have tobacco and alcohol habits to stop both. Limit caffeine. Current guidelines are no more than 3 caffeinated beverage per day, and it's preferred that they try and avoid this during the whole first trimester. Counsel about exercise. Whatever they were doing before is okay to continue, but don't start something super aggressive during pregnancy. They are to avoid over-the-counter medications and supplements. Studies have shown that the average pregnant woman takes 7 over-the-counter medications during pregnancy that we are not even aware of. So we want to bring that up at the first visit. We avoid raw meat and fish because if she acquires a bacteria or a parasite, we may not be able to treat it because she is pregnant. The treatment can harm the fetus. We avoid douching. It's okay for them to continue to have intercourse unless there's a problem, such as bleeding. We also introduce the Harmony test and the maternal serum AFP/triple marker. Once again, this is on your preclinicals related to diagnostic testing. So our patient comes in, hopefully in the first trimester, early, between 6 and 8 weeks. Typically, we will see them every 4 weeks during the first trimester and the second trimester. Once they hit 28 weeks, we see them every 2 weeks until they're 36 weeks, and then we see them once a week. Anytime there are problems, then we will have the patient come in sooner. I just want to mention one other thing. If you go back up to the previous slide and you look at the blood tests, if a woman has risk for diabetes, we may screen at that first trimester. with a 1 hour postprandial glucose. It's actually a 50-gram challenge. So this ends the lecture on health maintenance in the first trimester.